But it's 1:33, so let's go ahead and get started. So I want to thank everybody for jumping on another Compliance podcast session. Today I have Dr. Delgado pinch hitting for me, and I'm pinch hitting for Ray because he's out of town at a MGMA conference. So hopefully he comes back with all kinds of fun information and exciting stories for that. So today we've got something that's I believe is right up my alley. And what I mean by that is we get to talk about health insurance, and not in the boring way of how does it work, but in the exciting way for them getting finally recognized for doing the things that they've been doing for at least a decade, but now it's catching up to them in a variety of different ways. And the interesting thing is that this one insurance has been in the news for a lot of different things over the last year. So, Dr. Delgado, thanks for coming on. And for those of you that do not know what I'm referring to, I am referring to United Health Group. So we are, where is this one? Hold on 1 second, because I want to share. All right, it's here. So for those that haven't gotten to look at it, because I know that Ray put it in the invite, basically United Health Group is getting squeezed from all sides. So last year they were getting looked at because of the merger. So part of the federal government during the Biden administration was having issues with their proposed merger with another larger insurance company. Then we have the issue with Luigi Mangione, or supposedly Luigi Mangione, and the United Healthcare CEO's assassination in New York City. And then now we have in Florida, which I doubt that this is going to be the last state that does it, but we have a class action of 17 hospitals suing United Healthcare for underpaying for emergency services. Now, this is interesting to me because at a glance you think, okay, United Healthcare, most people don't normally think their Medicare or their Medicaid plans. You think of their private pay plans. The hospitals did not pick the managed care plans, the managed care Medicare or Medicaid plans, which anyone that has billed United knows they underpay on those when you're in network. Forget about out of network. Then you have these ones are specifically the plans that are on the exchange is the ones that they're suing for.
Wow.
United Health is saying, hey, no, you can take us to court because you're not in network. However, the problem lies if you are in an emergency, and anyone that has had someone in an emergency, you don't get to pick and choose your hospital. The ambulance is going to take you to the first and closest available.
Right.
I mean, I'll tell you quite honestly, I wish I didn't have to go to my closest hospital most of the time. But hey, that's just the reality of emergencies. So, in order to be a community hospital, especially in Florida, there are quite a few different hoops and hurdles bureaucratically that a hospital has to go through to be a community hospital. And there are plans that they have to take. They have to take every patient that comes in for emergency in that area. And then if that patient needs to be escalated to, for example, a trauma center, then that goes out to a trauma center, right? This is interesting to me because these are Obamacare plans, EPACA plans, and United is saying, well, you're not in network, so bye. I don't care. I'm underpaying you because I'm paying you whatever I want to pay you because you're not in network. So I would look at this as the hospitals are using this as the way in to hit them with the other lawsuits. Strategically, that's what I'm thinking. I'm thinking they're going for the one that is least likely to succeed so that then they can hit them with the other ones once this one goes through. What do you think, Dr.
Okay.
Delgado?
I actually want to add a couple of things because this is not something new, and all the factors, all the information available points to the same thing. So for all of our, I would say, attendees, listeners,
Mhm.
the one thing that actually this came out from the Department of Justice, no, from the Office of the Inspector General, that they were looking at a study when commercial insurances were actually denying, and I think it was an 8% of all claims that should have been paid. So
And it
they,
was United that was in problems with that in California because they were using an AI and PBMs, and that lawsuit is going through favorably for those pharmacies and those hospitals that were part of that suit.
yeah, but this was a study about
No, no,
basically
no.
all commercial insurance.
I know what you're talking about, but
So
I'm specifically mentioning the suit, so anybody can
yes,
look that up.
yes, and this is something that about 4 or 5 years ago, believe it or not, because I'm one of the federal government contractors, I received the proposal from CMS to create a system that will audit all the claims. And the idea was to use AI to identify trends and deny claims. It's just that insurances took it a little further. So now this is where I'm looking at, because people say, well, that's not fair. That's not illegal. When you really look at it, they have been actually underpaying us for over 10 years. And
Easily,
it's malicious,
easily.
it's with intent. But if we
Yes.
do one or two mistakes on the claim, we get nailed. They are not paying on time. I mean, there's a state and federal law that say that at least 30 days after a clean claim, they have to pay. But they're getting the clean claim and they're denying it outright. It doesn't matter whether you are participating or not. So what we see now is almost like a chain of events that they have been abusing the providers, the healthcare professionals. They have been also taking advantage of the government because they
Well,
say,
hold on. That's the part two. Let's hold on
I
to
know,
that.
but
Don't jump the shark.
let me put all those two there. And now, basically, they still saying, I'm innocent. But in the meantime, why is it that you're going to see a lot more change of hospitals that are not taking the insurances? Period. Then there's a little more because this is how it's going to hurt us, a healthcare provider. They will never lose money. So what they do is, as they react to this and they know what's coming down, for example, Humana is going to increase the amount of funds in the reserves. But where do those funds come from? From all of us that are participating in Medicare managed care. All they're going to do is, oh, we're looking into going on a risk proposal, this value care. So that means that now the money that I'm going to retain from you is going to increase. And that money, even though I say is yours, you don't get any interest by me holding that money.
Yeah.
Now they're going to be paying less, doing renegotiations to pay less. Now they're going to do different things to recoup that money. So the burden in terms of carrying the cost is going to come back to us. And what do we do? But
Well,
go
so
back to your jaws. I'm just saying that this has been coming for now quite a few years.
100%. I've been waiting for something like this for some time. But I find this interesting because, again, with the different interpretations that we've been finding for no surprises and things like that, I
Yes.
was expecting that when I opened up the civil complaint that they were going to hit United for the No Surprises Act and for underpayment on the Medicare and Medicaid pieces. But because they went with this one first, I think they're waiting to see how the civil court and the judges write the legislation and then hit United with the next one and then hit United with the next one. So the penalties from the first case are going to feed the lawyers that go through for the second and the third one, to be able to push
Yes.
those stronger cases through, right? Now it is interesting. You alluded to it. I do want to mention this as well because this was part of it. United is also under a DOJ probe,
Right.
and this one is for overcharging Medicare and Medicaid. So United And I'm going to say it, all of these private insurances
Yes.
have been overcharging the client, underpaying the providers, and keeping the cash and blaming everybody else but us. It's not me, it's you. They're trying to literally be that Spider-Man meme. They're pointing at everybody else. No, it's the federal government because they're bad. They're not giving us the funds to take care of you. No, it's the providers. They're lying to us and overbilling us. No, it's the hospitals. No, it's the this. It's never our fault. We're the insurance company. We're here to help you. When even the patients are starting to get wise to this now.
Yes. Yes.
And I'll say it flat out. In our mental health care practice, we have actively taught our patients how to get reimbursed from their own plan. And you would be shocked by how much easier it is for them to get reimbursed than for us to get paid.
Yes.
It actually infuriates me a little bit because I had one patient literally tell us, "Oh yeah, I just submitted it online and I got a check in 5 business days."
Wow.
I'm like, for 50% of this? No, for 100%. I was like, I was like, I don't have a note in here saying you needed the note or anything or a prior auth. They're like, nope. All I needed was the super bill you gave me.
Yeah. Well,
I am, I was I was happy for the patient, but I was furious. And so to see that the DOJ is actively and publicly going after United for this, and then seeing this class action from the hospitals, and that it is just, I'm enjoying myself. Now, I do understand why the insurances are, and it's important to understand why these insurances are doing this. One, because they can. Two, because they are a for-profit company, and all of these insurances are publicly traded.
yes.
Every single one of these major private insurance carriers are publicly traded, which means they are beholden to the shareholders, or the whole board gets fired every year.
Yeah. But
So,
okay.
and then when you get to make your own rules as you go, it makes sense that we're like this.
Okay. So let me give you a pause here because the key here is what are we trying to say? Well, in a way, we're trying to say that number one, all of the insurances are being caught with the hand
And in
on
the
the,
cookie jar, literally.
which we knew because we have been complaining for a long time that we are not getting paid for the services we do. Number two, that is even more important because it's something that people still don't realize, is that the customers that we have, the patients, are realizing that they are paying $1,000 a month, $1,500, $2,000, but they don't have a network, nor do they really get covered anything because, I mean, your mother, for example, and I'm not going to say for what, but I will tell you that she goes to the doctor and then she pays for $74, $80. That's her copayment. So, okay, so what the heck are you covering? Because evidently that's more than what it would be a regular office visit. So the question here, and what I'm looking at the number two part, is that people say, well, if you don't accept all the commercial insurances, people will not come to your office. And not true, because right now in primary care, and I did a study during the weekend, we're looking at 2032, we will have 34,000 deficit in terms of primary care provider, which we can see now. I
Yeah.
know one person that we know, our mechanic, that he basically had Aetna for about a year, and he had not been able to schedule an appointment or establish himself with a primary care provider because nobody is, they will
Taking the
make typical
product.
patient, but they don't see you. They don't have that. So, and then for the people that actually are able to establish themselves with a primary care provider, the waiting time in the area is 4 or 5 hours because there's not enough providers. So people are starting to look at it and say, I may have insurance, but I don't have through these services. So that's what's going to push it into why should I pay $1,500 a month or $1,000 a month for an insurance that doesn't cover me and now go to the doctor? I'll pay $200 for the visit and that will be cheaper. So it's getting to the point of, and I always say this is a pendulum in healthcare.
Mm-hmm. Mm-hmm.
I remember that at one point in time, everybody was cash. Nobody believed in insurances. Then insurances started coming in and they say, oh, okay, great. I get a discount. I go to the visit, $20. Okay. Then came capitation, which is not called capitation anymore. And say, okay, perfect. They also say, I'm making good money. I don't even have to see the patients. Then it dropped back to capitation didn't work. So we
Or
were
fee for
back
service at that point.
for service. And then in the last couple of years, they have been talking about concierge. And now they're going back to value care because it's cheaper for organizations like Medicare, CMS say, I'll pay you this much. I don't care what you do, but anything that about the cost of the patient is on you.
Yeah.
So we got to look at it. All of these law cases that are moving forward, all these things. When I see a hospital that is not accepting insurance, that is suing the insurances, that's big because you know that a visit to the ER for anything is $25,000.
Yes. Yeah. For an IV bag and an Advil, you know, like and it is absolutely wild what some of these things how some of these things are going. I mean, it is these cases really bring hope to me as someone that's running and as someone that's talking to smaller practices because everybody's getting hosed and they're frustrated because when you
Yeah.
have an AR that is inflated, but even at the uninflated real number, you're still looking at the salary of an entire provider and you're floating that the whole year. The healthcare industry is the only one where you do the service now and you get paid a month later, hopefully.
If you're lucky.
If you're lucky. This is the only industry. Your mechanic doesn't do it. Your plumber doesn't do it. That one I know for sure. Your electrician doesn't do it. Your accountant doesn't do it. Your lawyer definitely doesn't do it, right? So they're the only industry that literally will provide the service now and will get, and by the time they get paid, the client forgot that they even went to that provider on said day. That's happened quite a bit before too. Because you're sitting here playing the game with the insurance for 3 to 6 months to get paid. Then they finally kick it to the patient, and the patient's like, "When did I go see you? What did I go see you for? This is from last year." Well, yeah, you wanted us to bill your insurance. We had to play the game, like we send it clean originally. They kick it back and say, oh no, you need the prior off. They kick it back and say, hey, that's not medically necessary with this diagnosis. So then we have to pick a different diagnosis that it'll pay for it. And then they kick it back for something else. It's just, the game is just frustrating and expensive.
Okay, so let me stop
So,
you there. Let me ask you a question. And let's try to limit first. In
yeah,
terms of the case of United that you're bringing up, what
yes.
is the point? What is it that you are trying to tell us in terms of that case?
I am saying I am dancing on the grave of UnitedHealthcare right now because they're going to end up having to pay this out. They still haven't paid for the change breach. The DOJ is coming after them for the merger, and the DOJ is coming after them for the overbilling of Medicare.
Okay, so now, okay, so those are the points. How is that affecting me as a healthcare professional?
That's a great question. That basically says to me, stop doing business with United.
But if United is not the only one, it's all of the insurance
Agreed. But
under the
United is
same
the one
thing.
that's in the news right now. Humana will get theirs, Cigna will get theirs, Aetna will get theirs. But I am I am of the opinion that every practice needs to take a look at their payer mix. And if their payors are not paying them appropriately or at contract levels, you need to drop them.
Okay, so
This
now let
isn't
me ask you a
sustainable.
question. Okay, So, but this is the other issue that I want to tie to this thing. Lately, you will see that there are fewer and fewer practices owned by the providers.
Yep.
The venture
Yep.
capitalists are buying. And when
Yep.
they see this challenge, they don't know healthcare. They don't, I mean, they may, but all they're doing is
Well,
flipping,
hold on though. That one is interesting. What venture capitalists and what a lot of these smaller MSOs are doing and these ACOs, and you know this, they're getting to a magic number of a certain amount of lives with a certain carrier that they have a positive relationship with.
right?
And the end goal is to get bought out by that insurance carrier or
Yeah.
that hospital system. That is the end goal. From what I've seen, it's usually between 30 and 50,000 lives. And the bigger the network, as in the wider geographically you have this network of 30 to 50,000 lives, the more exponential you can get this valuation to. So the first flip will be I'm going to buy, I'm me as a single practice will buy another practice. Then from that double practice, we'll get some seed money to buy five more. But we're going to focus, we're going to hyper focus on one insurance because that's what they always do. They always end up hyper focusing on one insurance or one population because they have an end buyer in mind and they're planning that from the beginning. They're not doing that as it happens.
Okay.
That's not that no one trips over a banana and does a backflip like that.
So let me share something that I have found. One of the things I've found because I'm recruiting all the time is that all of a sudden I'm talking with a doctor, with a mid-level, that they say, listen, on Friday they told me that they were closing,
Mhm.
and on Monday I didn't have a job, or I was kept to do on-call for emergencies, but the office is closed. So I don't have a job all of a sudden. So the question here is, what is the path forward? Because healthcare services will always be needed.
Yep.
Uh, the idea for me is always been, if you don't like what's going on, what will you do? How do you change it so that you can do what you want to do? Which in my case, I look at it, patients always come first, provide good
Yep.
care for the patients. But then having a stable platform, to say it like that, where I can provide those. And in order to do that, I need the money to pay for my expenses because I may be nice, but I cannot pay out of my pocket so that I can work. I prefer to
Yep.
get paid and not work than to pay, not get paid and work.
Yeah.
Okay. So all of these lawsuits are happening, all of these government cases are going on. What is my takeaway in terms of what do I need to do?
I look at it three ways. One, I need to know how much it costs me to do my services. An
Okay.
actual number. Most
Okay.
small practices have no clue.
All right.
Once I have that hard number, I need to take a look at all the revenue sources. Are they paying me that number or not?
Okay.
And if they're not, ah, you know what I mean? Like it's just that simple for me. Um, but even something as simple as providers and the industry, especially smaller practices, need to learn and need to stop signing insurance contracts without getting a fee schedule first.
Yes.
When I'm negotiating with a health insurance company about the fees they're going to pay the practice, and the people cannot give me a fee schedule, cannot or will not give me a fee schedule before we sign a contract, that is a major red flag for me.
Yes.
But
Hmm.
the conveying the prevalent opinion has been sign the contract, they'll send you patients, you'll make money, it'll be fine. Just take all the insurances. That's not true. It may
No.
have been true 30 years ago, but that's not true now. And even 30 years ago, the PPO versus HMO conversation was happening.
Yes. Well, I can tell you, 30 years ago, I was the person there. I did my first cost analysis on a pediatric practice 31 years ago. 30 years ago. Then after that, I was the one doing the negotiations with the insurances, from the PPOs to the HMOs. And at that point in time, I remember, depending on who you were, everything was above Medicare. No one
Yeah.
would pay you Medicare, no one would pay you below. Then about 10 years ago, I was doing an audit in an office, and the doctor, I remember always, he said, "Oh," and I said, "Are you getting paid properly?" And he said, "Yeah, I'm getting paid Medicare rates." I said, "Oh, really? Let me review your contracts anyway, as a courtesy." And what I found out was that he was getting paid at based on Medicare rates at 40% Medicare rates. So all he does, he look was Medicare rates.
Mhm.
40% of Medicare rate, that means you're losing money with every patient, every services you do. So the question goes back to what you were saying and am I making really money by taking this insurance or this product for all of that? I mean, I'm looking right now at the self-insurance, the cash, Medicare traditional, we can still play with, and the sample of Panacea, which is the practice that we mutually own, that when we work with insurance companies, we're getting a lot of patients, but the amount of money wasn't enough to cover costs. We stopped that, and yeah, we hit a low, but now we're actually seeing less patients and making more money.
And it's less stressful. And we have less cost. Our
Yes,
cost to bill anything is nothing because we're only billing Medicare.
yes,
Everything else is cash.
yes, yeah,
The cash flow is completely different.
yes. Well, it's like when I look at certain things and I say, okay, wait a second. So if I'm going to send a letter,
Mhm.
sending you a letter costs you anywhere between $7 to $15. And people don't think
Yeah.
about, no, a letter. No, because
Yeah.
when you put the time, the ink, the computer, the paper, the postage, the envelope, you're there. So that it was kind of funny because at one point in time I say, any claim below this money, don't bill them. And they look at
Yeah.
me kind of funny and say, but it's money we're leaving on the table. I say, no. It's like President Trump says about the penny. One
Yep.
penny costs 4 cents to make
Yep.
it. Why do we want to make any more pennies? We're
Yep.
losing. So it's the same thing. Is we gotta look at healthcare, I would say, from 2 points, or actually three. One is for the first time it's coming to light what the insurances have been doing. Okay. That is going to affect us because they're going to pass all the costs to us, one way or the other. So at that point in time, we got to look at it from a different side. So if, okay, what services I really do that make money. Any service that I don't do that I do that doesn't make money, and sorry, but I love it, but unless it's a loss leader that I'm doing it to attract patients so they can do other services that make money, I cannot afford to do it. And then the next
Yeah.
thing is who do I want to play with? Because if United, I know it's already in trouble. I know that all they're going to end up with a settlement of a couple $100 million at the end. I mean, they are still making billions of dollars in profit. Where's the
Oh,
money coming
absolutely.
from us? Because they're underpaying us. So at the end of the day, I say, okay, so I see that coming. It would be smart for me to actually limit the number of those patients I see, or even take them out altogether. Because otherwise, one way or the other, they're going to pass the cost to me. And it's
Yep.
not going to be immediately, but between I would say after summer and the end of the year and next year, ooh, it's going to be ugly. So it depends on who you are, what services you offer. It's almost to the point of look at you from the standpoint of being selfish in the business. Because if you don't make money, you will not survive, period. That's it. You cannot provide services if you're not making money.
So I obviously agree with that, but there are a couple of things that I think can be done and should be done. If you look at dental and chiropractic care
Yes,
teaching models, they have a component of teaching the providers about business.
yes,
And that is something that is, we have been harping on this for years, got decades now. That is something that is a missing from traditional regular healthcare models. Your MD, your DO, your nurse practitioner, your PAs, they're not getting business classes. They're
Yes.
barely getting coding classes. Let's be clear.
Yes.
They're barely getting coding classes. So I think that needs to be changed on the front end. On the back end, when they're in the field, I I think that it's a conversation of, do I even bother taking insurances at all?
Yes.
Because in certain specialties and in certain markets, there's nobody there. I hate to put it like this, but if there's nobody there, there's nobody there. What are the options for the patient? When CMS and HHS are saying that patients shouldn't have to drive more than 50 miles to see the provider or see a specialist.
Yeah.
And I'm sitting here saying, well, there's only four, and I'll use Fantasy Alliance. There are four psychiatric practices in all of this county. How many of them are accepting new patients?
One.
One.
How many accept insurances?
The other three.
They accept insurance?
But they have their catered to business. They're not accepting new patients.
Uh,
They may take Medicare ones occasionally, but realistically, they're not taking new patients.
wow. Yeah.
So,
Okay. So you
but
present.
the point is this though, right? Like this one was a fun one for me just because I wanted to, dance on the grave of United and hope that all of the others either learn from this or prepare themselves to have the same issue come up. If anybody's got any questions, please throw them up. We'll be more than happy to answer them. Anything hyper specific, just email Ray or myself when we can talk about it offline directly. But realistically, it all comes back to the same thing. If the hospitals are finally getting mad enough to where they are suing the insurances, when are we, the smaller outpatient offices, going to get enough stones and anger to do the same thing?
Again, you're right. I cannot
When are we going to do
disagree.
that?
Yeah. But I'm actually always looking at what can we do to help our customers?
Agreed. But the only thing that we can do is
Yes.
as
Well,
to educate the patients as to what their insurance product is actually giving them. That's the only thing that we can do because there are laws in place saying that we can't talk to patients about their insurance product.
yeah, no, but no, that's not what I'm talking about. Our customers are not just in this format that we are. It's the practices, not the
Yeah.
patient. So
Well,
what I'm
without the patients,
looking
there's no
at is
practice.
maybe what we want to do is create what you basically said, or the modules to educate our customers so they can identify, so that they have tools to be able to say, this is not worth what they're paying me. This is basically what I need to do for the providers to say, oh, okay, so these are the options, and this could be the model that I can implement in my practice. Just giving them just basic ideas, and then the details we can work with them one-on-one. But at least start educating them of how to identify the problem and how to identify potential solutions. Is what I'm looking.
So I would say I would want to gauge if the market's even interested in something like that before you even
Yes.
start doing it. Because
Yes.
that's going to be a lot of heavy lifting on us on the front end. And I don't know what the ROI would be on the back end. Because the types of providers that care about the numbers already care about the numbers and they've already kind of figured it out or they're on their way to figuring it out quickly.
Yeah.
It's the ones that, and you know what I mean? Like, because we're at a very interesting spot too with the provider population. We have an entire large segment that is closer to Medicare age than their med school age. And
Yeah.
the med school students coming out right now aren't necessarily looking until they get burned by a larger organization, are not looking to move into the smaller practices.
Yes.
So like it's almost a generational gap. because you right now I don't see, when I look around in the market here in Florida, I don't see that there are a lot of providers in that 45 to 55 range. There's guys and girls right out of school, so mid 30s to early 40s, and then there's the guys that own the practices that are damn near Medicare age themselves
No, or pass.
or past Medicare age, right? Like they are a perfectly good client for their own practice. So it's a situation where it's a very interesting spot.
Yes.
You know, it's
Yeah. And what I'm finding out is that the younger physicians prefer to be employees so that they don't have to deal with all the garbage or
they
the
don't have to deal with
overhead
this.
manager. Yeah.
They don't have to deal with this.
Yeah.
But it's almost like they don't have to deal with this until they say, hey, the grass isn't greener on the other side.
Yes.
I'm being pushed around. I'm being arguably even coached as to what to charge, how to charge it, so that way the insurance will pay out, which we have seen during all kinds of scenarios in the last 5 years. Not going to name any names, COVID.
It's the TikTok
that's what
earlier.
it is.
It's
Is
going
the
back.
gener we have
It's
to
coming back.
we have to see how we can survive this time period over the next 5 years for this new crop of providers to get burned as employees, so that way they understand they want to move to something else
Yeah, no, I
because
don't
they're
think
chasing the dollar.
it's not going to take 5 years. Based
I
on
don't think
the
it'll take 5 years,
going
but I'm
back to
saying
the
5 years
main,
just because
yeah,
it's
now going back to the main topic, the United Legal
Mhm.
Pro. Let's put it like that. I would say that within the next 2 years, we're going to see a chief, and the chief is going to start by the end of this year. Where
Yeah,
because I'm
yeah,
already see the patient saying, I'm not gonna pay for that insurance, I'm gonna pay cash. Or I'm not gonna get insurance, or I'm gonna wait
yep,
until I'm dying before I go to the hospital because I cannot
yep.
afford it. So I do see the changes. What I want to do is get ahead of the trend so
Agreed.
that it's like in a wave. There's a big wave coming in. You don't surf after the wave. You don't want to be in front when it crashes. You want to be just
Yes.
right so you can ride the wave. There
Yeah.
is an opportunity to do that now. But if we
Yes.
miss that window, you're going to have to change completely your business model. And that's what's going to happen. A lot of businesses are going to crash because when United settles, because they are not going to
They're not
close.
going to go bankrupt. They're not
No,
going to go
they're going to
bankrupt.
settle. They're not going to then come up with new ideas of how to pass the cost to us so they can recoup that money, so they can show profit and they can keep on going. So it is on us to make sure of how do we survive that wave or how do I ride it to my benefit? That's what I'm looking
So
at.
again, it goes back, know your numbers. If you
Yes,
go to any business school, even the ones that are crappy, they will tell you if you don't know your numbers, you're not running a business.
yes, yes. You're right.
You got to know what the numbers are.
Yeah.
You got to. You've got to. So,
And you have to stay in tune with what's happening around you.
yeah.
Because
Yeah.
for every practice I work with, I look at the actuaries, and the actuaries are the patient population. What is the kind of
Yeah.
patient population is in that area for me to know what kind of provider I'm going to put there, for me to know what kind of service, and even the marketing. Marketing is becoming more important than ever. I mean, if
Yeah.
you don't invest in marketing, don't expect that because you put the shingle out there, patients are going to come in.
Yeah, those days are done. But yeah, so next week I want to thank everybody for coming in. I don't see any questions right now. But yeah, if anybody's got any questions or concerns, please let us know. We'll answer them here over the next 5 or so minutes, and then next week Ray will be back. He's after his little jaunt in Vegas with MGMA, and we'll go over the topic that he had set up. I don't even remember which one it is. I usually let him handle that stuff, you know. One thing I forgot to mention over here when I was looking at this, which you'll find interesting because of the type of numbers you look at all the time, Dr. Delgado, is under under one report over here for this DOJ and United. Sickness scores for United Health patients transitioning from traditional Medicare rose by 55% in their first year in Medicare Advantage, compared to a 30% industry average.
But you know what?
So in layman's terms, what they're saying is that if this traditional Medicare patient had one diagnosis, UnitedHealthcare found a way to get 5 diagnoses on that patient, so they could bill traditional Medicare more because of the level of complexity that the patient is. Remember that the way these insurances are getting paid out is not fee for service like us in the trenches. They're getting paid based on complexity because they've been on full risk for 10, 15 years. Actually, since the PPACA, they've been pretty much on risk. The difference was that we were paying for it for the first 5 years the PPACA passed. If anybody remembers the insurance corridors.
Yeah.
The insurance corridors. That's how they were making their money for all these plans.
Yeah. But and again, we could be talking about just insurance products and the new products that are going to come out, because they are also
all the
playing
same
in terms of,
crap.
they're
all the same
moving
crap.
patients from one product to another product because they can make more money on that product and they pay less to the provider. So it's all kind of games.
It's literally a situation where we go from HMO PPO, to then we call it something else.
Yes.
Now, I don't know if anybody's realized this, but if you have a Medicare Advantage product, it may say PPO, but it's an HMO.
Yes.
You may have a PPACA product from the healthcare portal or the exchange or whatever it is in your area. It's an HMO product, borderline Medicaid product.
Yes.
And the only reason why I won't assume it's a Medicaid product outright is because I don't know every single product on every single exchange. But here in Florida, if you have an exchange product, it's a Medicaid product.
Yes. Yeah.
They just branded it something pretty.
Yeah. It just, again, they change the names.
Yeah.
But the concept, and that's why I say, what is the intent? What are they trying to do with this thing? Well, I don't care about the name. There's only so many ways you can name it. Actually, there's almost infinite ways, but there's so many ways that you can see patients and get paid for patients, and people make money by doing that. That's all there is.
Yeah.
So,
and we have to be careful with how we say it, because if not, it's fraud.
Yes. Okay.
So yeah, perfect. I don't see any questions here, so I want to thank everybody for coming on. This will be up on our YouTube here probably, I want to say Thursday or Friday. And then we'll be here next week. If you want to check out any of our previous episodes or you missed any episodes, please feel free to hit up the YouTube channel. You'll be able to see it there. And if you've got any questions or concerns, please feel free to reach out to us. All right. So thank you, Dr. Delgado.
Okay.
Thank you, everybody.
Good afternoon.
Have a good one.
Sunshine.